Our next speaker, pioneer ENT consultant, head of department in Reem Hospital, Dr. Ahmed Nofal. He will give us talk about Revolution Pediatric Adenoidectomy with Endoscopic Coblation.
Thank you. Thank you very much. Thank you very much. Thank you for all the attendance. Special thanks for Dr. Dina for this invitation. Now the time of surgery. As we coming now, if we'll speak about surgery, we'll choose the most common surgery in the pediatric age group, what is more than adenoidectomy. And we'll speak the adenoid here, or adenoidectomy. We'll speak about how to do it safer, faster, more precise. And in this presentation, we'll cover 6 points about the adenoid. What is the adenoid? And what is the pathological condition that affect the adenoid? And what is the indication of adenoidectomy? How we can do adenoidectomy? And we'll go for how we do adenoidectomy in Reem Hospital, about our technique, and what is the benefit, or what are the benefits of our technique in Reem Hospital. Adenoid is defined as a mucosa-associated lymphoid tissue which found in the roof and the posterior wall of the nasopharynx. It extends from the nasal septum anteriorly to the area of fossa of Rosenmuller, which is behind the Eustachian tube. It is covered with respiratory epithelium, which is pseudostratified columnar ciliated epithelium. The free surface of the adenoid, or the other name is called the pharyngeal tonsil, has fold and fissure, and inside there is a median blind recess, which known as the pharyngeal bursa or bursa of Lasker. So the adenoid is part of the lymphoid tissue which is found in the upper aerodigestive tract, which forming the Valdeir ring. We have the adenoid, or the nasopharyngeal tonsil. We have the tubal tonsil in the opening of the Eustachian tube. We have the palatine tonsil, with the famous tonsil. We have the lingual tonsil. What is the difference between adenoid and the tonsil? Adenoid is covered with hemicapsule. The tonsil is capsulated. Hemicapsule separated it from the superior and posterior wall of the nasopharynx, and it has no cryptis like the tonsil, but it has folds known as pleats, and it's covered with the respiratory epithelium, which is pseudostratified columnar ciliated epithelium. The adenoid found in the children, and it reaches peak or maximum size by the age of 5 to 7 years, and should be involuted by the age of 8 to 10 years, and it should be typically atrophied by the adulthood or adolescence. What are the pathological conditions that can affect the adenoid? There are many pathological conditions. We'll come one by one. The adenoid hypertrophy or adenoid enlargement, which causes nasal obstruction, mouth breathing, snoring, even attacks of obstructive sleep apnea. And the causes of adenoid enlargement, either infection, which should be either bacterial or viral, allergy, irritant, even the reflux can cause adenoid hypertrophy. Another thing which can affect the adenoid, which is adenoiditis, inflammation of the adenoid, or repeated infection or inflammation of the adenoid, which would be either acute or chronic. Chronic if the persistent more than 90 days. And the pathogens or usually affect or causing adenoiditis, either bacteria like Haemophilus influenza, Streptococcus pneumoniae, and Staph aureus. Virus like rhinovirus, adenovirus, or even Epstein-Barr virus. And if there is adenoiditis, it becomes as a septic focus which transmitted infection to the nearby structure, either to the side, spread the infection to the ear, leading to repeated attack of acute otitis media, or to the nose anteriorly, leading to sinusitis, or down to the tonsil, leading to tonsillitis and peritonsillar abscess. If the adenoid is big enough and cause complete obstruction of the nasopharynx, may cause attack of apnea attack, which is obstructive sleep apnea. Also, as it is a nearby structure and it is related to the nasopharynx, related to the pharyngeal opening of the Eustachian tube, it may block the Eustachian tube, leading to accumulation of the secretion behind the middle ear, which is known as otitis media with effusion, or the glue ear, or transmit the infection to the middle ear, which is leading to recurrent attack of acute otitis media. And also with chronic adenoiditis, it may form a resistant form of bacteria, which is called the biofilm, that's resistant to the antibiotics. And rare pathology can happen, either a benign neoplasm, which is famous in the teenager male as juvenile nasopharyngeal angiofibroma, or the adult, the lymphoma or the nasopharyngeal carcinoma arise from this area, which is the fossa of Rosenmüller behind the Eustachian tube orifice. Also, immunodeficiency associated hypertrophy as HIV infection can cause adenoid enlargement due to the chronic antigen stimulation. This is the condition that can affect the adenoid. But we'll come now, what are the indications for doing the adenoidectomy? There are mainly one of these 4 indications can be indicated to doing adenoidectomy. The first one, surely the obstruction. The obstructive, if the child complaining from obstructive sleep apnea, which is leading to snoring, mouth breathing, difficulty of breathing during sleep, even the parent notices that their child cessation of breath during sleeping. And the definition actually of apnea, if the cessation of breath more than 10 seconds, this is considered one attack of apnea. So this is one of the main and the commonest indication. The second indication, if we have an ear complication related to the adenoid. One of these ear complication, if the child complaining from diminution of hearing or hearing loss, if the adenoid is big enough to obstruct the Eustachian tube orifice, leading to accumulation of fluid behind the ear, leading to otitis media effusion. Also, one of the indication, if the child is the adenoid makes as a source of infection, leading to repeated or recurrent attack of acute otitis media. If there are more than 3 episodes in 6 months or more than 4 episodes in the year, this is indication for doing adenoidectomy. Also, if it is the child, or when you examine the ear, you found a retraction pocket and the start of development of cholesteatoma. In this case, we have to do adenoidectomy to avoid development of the cholesteatoma. Also, if there is a repeated infection, as we said, if the adenoid leading to chronic adenoiditis, more than 4 episodes in the year, if persistent of the symptoms in spite of taking 2 courses of antibiotics, if it is adenoid which leading to transmit of the infection leading to chronic rhinosinusitis, and the child complaining from persistent mucopurulent nasal discharge, if the infection transmitted down to the lung and leading to repeated attack of cough and chest infection, in this time we have to think about doing the adenoid. If the adenoid is neglected and it's big enough to do craniofacial affection leading to malocclusion with dental prognosis. So this is the indication of adenoidectomy. What are the contraindications of doing adenoidectomy? Actually, this is changed now with the technique, but we have to say there is absolute contraindication. One of it is if the patient has cleft palate or submucous cleft palate. And as we see now, our technique can bypass this problem. But we have to know that if the patient has cleft palate, why the adenoidectomy was contraindicated for removal of the cleft palate? Because if we remove the adenoid, you will lose the closure effect with the soft palate with the posterior pharyngeal wall. In this condition, the child will complaining from velopharyngeal insufficiency, leading to hypernasality and regurgitation of fluid and food from the nose. So to have to be take care if you're doing in a patient with a cleft palate or submucous cleft palate, and you can know it by seeing the bifid uvula. There is a relative contraindication if the patient has bleeding disorder, if the age younger than 1 year of age, if the patient have a neuromuscular disorder like cerebral palsy, we are fearing from aspiration risk. However, these all are relative contraindication, and if the patient really have a cause of obstruction leading to obstructive sleep apnea, struggling during sleep, struggling to taking the breath, we have to think about doing the adenoidectomy. What are the techniques for doing the adenoidectomy? There are many techniques for doing the adenoidectomy. We'll try to summarize or enumerate most of them. The most common technique and the wide technique is conventional curettage of the adenoid. This is a simple technique, a rapid technique by going with the curette behind the through the mouth in the nasopharynx and do curettage for the adenoid. It takes about few minutes, 1 or 2 minutes, then put a back, then 5 to 8 minutes it will finish the procedure. However, with this technique, the procedure is, or the operation done blindly. Even we go first to palpate the adenoid and then we do it blindly. But this is a problem with this technique. There is a remnant can be present in after removal of the adenoid, and it's reported that about 30 to 40% there is a remnant after doing the blind adenoidectomy technique, and this remnant is predisposing for regrowth or development of the adenoid recurrence after the surgery. Also, this technique have some blood loss, which sometimes reach from 90 to 120 milliliter. But it is a cheap technique and almost costless technique. But the problem with it is injury of the nearby structure, injury of the Bastivan ridge, which leading to velopharyngeal insufficiency symptoms, which is sometimes reported with the conventional adenoidectomy, as it is a blind technique. So the next technique, which is doing removal of the adenoid with using suction diathermy. But the problem also with this technique, also it is doing a cautery in this area, but the monopolar and the bipolar give a high temperature, which causing tissue damage. The temperature reach from 300 to 400 degrees centigrade. So with this technique, also it is bloodless or even controlled bleeding, but it's cause thermal damage of the surrounding structure and affecting the prevertebral muscle and can be injury to the Eustachian tube. But it's good for hemostasis. The next technique, which is removal of the adenoid with the microdebrider, and this is usually done under endoscopic guidance by using the microdebrider is going through the mouth, and here is the scope through the nose and remove the adenoid. This is technique is also if it under vision, so the residual is less, reach to up to 5%. But the problem with this technique is more bloody technique, and the blood loss maybe reach 135 milliliter in the operation. So also this technique is less painful, but it has more loss of blood. The coblation. The coblation is done by doing a plasma field ablation to remove and do ionized layer under the saline cover to ablate and remove the adenoid. But the advantage of this technique or the advantage of the coblation is the thermal or the temperature. Do you remember the suction diathermy? 400 degrees centigrade. Here we have from 40 to 70 degrees centigrade. So the thermal effect is minimal. So the tissue damage is minimal. The pain is minimal. So this is a minimal pain. So precise removal, avoid injury of the nearby structure, Eustachian tube, pseudopharyngeal wall, preserve the Bastivan ridge, so preserve the velopharyngeal function. And with this technique, we can do partial, as we will see later, partial adenoidectomy. So we can do it in the patient with submucous cleft palate. Also, laser adenoidectomy, the laser also is a good technique, but the problem with the laser is it induces fibrosis effect, so it may cause nasopharyngeal stenosis, which is a very bad complication if it has happened. And the endoscope, as we said, the endoscope technique, which make us to do the procedure under vision, which reduce the incidence of residual to 0.5 to 2% and decrease the incidence of injury of the nearby structure, either using the coblator or the shaver here. This is a comparative between all the most famous technique. If we look here, the conventional curate, yes, it is has the least time, but the most painful one, and the main problem, the most residual tissue, which reach up to 40%, and this is the cause of the recurrence. Suction diathermy is still painful because the thermal effect of the diathermy and the monopolar. The microdebrider, okay, it has more blood loss. the coblation, especially with endoscopic coblation, the least pain, if you look here, the post-operative pain, it is the least one. If you look the residual tissue, it's 1.2, the least one. If you look to the blood loss, it's almost in the least one. So the main advantage of doing the coblation is less pain, less tissue injury of the surrounding structure, less residual, but the main problem, it is costly because the probe is disposable and it's costly for the patient. So what our technique we use in Reem Hospital. Before speaking about our technique, this is an interesting paper that I published in the International Archive of Otorhinolaryngology, and I think it is the first paper which published under the name of Reem Hospital, in which we did endoscopic evaluation after doing the conventional adenoid curette in 100 patients. And it was, we found this result. The remnant was found in 24% of the cases. And there is injury of the nearby structure, there instance of 23% of the cases. And there is bleeding point, which found in 13% of the cases, one of them was severe. So this make us to go for our technique that we usually use in Reem Hospital now, which is transoral radiofrequency adenoidectomy. We hold the probe of the coblation in the right hand and go with the left hand inside the nose, 0 degree, 2.7 endoscope through the nose, and start to do coblation and removal of the of
3 minutes.
Okay. To start to removal of the adenoid. Look here, this is the endoscopic 0 degree endoscope through the nose, and here's the coblation. Now we can easily remove all the adenoid tissue under vision. We can take care of the ossicular tube, and even also if there is enlargement of the tubal tonsil, we can do partial removal of it. So this is give a good advantage, and the pain is less. Actually, we can discharge the patient after 3 to 4 hours, and the patient even can go school in the next day. And also, it has less injury to the nearby structure, as we said, the posterior or lateral pharyngeal wall and the ostichian orifice, and the recurrence rate. Actually, we are about to publish this paper. We did 1,000 cases with this technique. And actually, 2 cases came to me complaining from nasal obstruction and mouth breathing after 6 months of the procedure. And when we go back for revision surgery, one of them was a large tubal tonsil. The adenoid was completely removed, and the obstruction, we did X-ray for them. We found the nasopharyngeal soft tissue here, and we found enlargement of the tubal tonsil. And from this time, I started to do shaving of the tubal tonsil while I'm doing. And the second case, I found swelling in the site of the adenoid. And I took it and sent it for histopathology, and it was not surprising to me, the pathology showing negative for lymphoid tissue. It was granuloma. So even the 2 cases out of the 1,000 case, they are not actually regrowth. One of them, enlargement of the tubal tonsil, the other one was granuloma, as proved by the histopathological examination. One of the advantages of this technique is the preserve of the velopharyngeal valve. Preserve of the velopharyngeal valve is important to avoid the hypernasality, which is coming after doing the adenoid, and avoid the regurgitation, which happens sometimes after of the food and the fluid which come after adenoidectomy. And also, it's important for this technique. I have this one patient who has submucous cleft palate, and he has obstructive sleep apnea, one of the contraindication of doing adenoidectomy before. But with this technique, we can do partial lateral adenoidectomy, meaning we remove the lateral parts of the adenoid and keep the median part. Keep the median part with help for closure of the velopharyngeal valve and prevent the velopharyngeal insufficiency. And removal of the lateral part will give the patient airway to bypass the obstructive sleep apnea. So our home message that adenoid is a mucosa-associated lymphoid tissue which is found in the roof of the nasopharynx, and the main indication is obstruction and recurrent attack of infection in the ear or secretory otitis media or malocclusion. and we have several techniques, and we found that the technique of transoral radiofrequency adenoidectomy under transnasal endoscopic guidance can offer a less pain and preserve the important structure, preserve the velopharyngeal valve, low recurrence rate, and also provide the capability of doing partial lateral adenoidectomy in cases of submucous cleft palate. Thank you very much.
Thank you very much.